Today, we're pulling back the curtain on something we all go through, the doctor's visit.
You know that feeling, right? You're sitting there on that crinkly exam table paper just waiting. Well, guess what? The second your doctor or nurse walks through that door, the exam has already started, way before they even think about grabbing a stethoscope. So today, we're going to deconstruct that whole visit.
You see, the very first part of a physical exam has nothing to do with instruments or tests. Nope, it's all about pure, trained observation. It's a skill, something clinicians call the general survey, and it kicks in the moment they see you. It doesn't matter if you're in the waiting room or already on the table. And this part is absolutely fascinating. Clinicians have to actively train themselves to fight against a natural human bias. Think about it. A skin specialist, a dermatologist, is probably going to notice a rash right away. A lung specialist, on the other hand, might spot something like clubbed fingernails, a subtle sign of lung disease. So to avoid that kind of tunnel vision, they learn a systematic approach to build a full objective picture of you.
So what exactly is this general survey? Well, you can think of it as a structured first impression. It's their objective look at your overall health, your mood, even how you're dressed and how you're carrying yourself. This initial scan basically creates the roadmap for the rest of the visit.
And the level of detail they're looking for is just incredible. Are you looking fit? Or maybe a bit frail? Is your clothing right for the weather or something off? They're checking out your facial expression, like the intense stare you might see with an overactive thyroid, or the sad affect of depression. Even scents can be a clue, like the fruity smell on the breath that can signal diabetes. Your posture, a slight limp, if you're fidgety, it's all data. Every little bit of it.
All right, so after that big picture observation, it's time to zoom in on the hard data, your vital signs. And here's the thing, these are not just numbers to be quickly jotted down in a chart. They're critical pieces of the puzzle, and getting them right takes a surprising amount of precision.
I mean, just think about getting your blood pressure taken. It feels so routine, doesn't it? But a tiny mistake in how it's done can throw the reading way off, and that could actually affect your diagnosis and treatment down the line. That's why getting it perfect is such a big deal.
So here's what the perfect procedure is supposed to look like. First, you should rest for 5 minutes, with your back supported and, this is a big one, your legs uncrossed. The cuff size has to be just right for your arm, because a cuff that's too small will give you a falsely high reading. Your arm needs to be supported at the same level as your heart. They even do a preliminary check by feeling your pulse to make sure they don't overinflate the cuff. See, every single step has a purpose, all to make sure the number is accurate.
And here's a little detail you can watch for next time. The head of the stethoscope is supposed to be placed right on your skin, over the artery. It should not be tucked underneath the cuff. Tucking it in there can actually bump up the bottom number of your blood pressure reading. It's a tiny detail, but it can have a pretty big impact.
Now here's a twist. Even with absolutely perfect technique, the doctor's office itself can be a problem. You've probably heard of white coat hypertension, right? That's when your blood pressure spikes in the clinic, but it's totally normal at home. But there's also its opposite, which is actually more serious. It's called masked hypertension, and it's when your reading is fine at the doctor's but high when you're at home. And that's exactly why you hear so much about monitoring your blood pressure outside the clinic these days.
So, we've talked about how clinicians observe you and how they take measurements. Now let's connect the dots and see how they turn those visual cues into a possible diagnosis. And there's no better place to start than the biggest, most visible organ you have, your skin.
Now, this is a tool that is incredibly useful for you too. To screen for melanoma, which is the most dangerous form of skin cancer, doctors use this simple memory aid. You've got A for asymmetry, B for an irregular border, C for any weird color variations, D for diameter bigger than a pencil eraser, and maybe most importantly, E for evolution, any change at all over time. It's just a really powerful, systematic way to catch a serious problem early.
But you know, it goes so much deeper than just moles. Clinicians are basically trained to be pattern recognizers. They spend years learning to spot the unique visual signatures of hundreds of different skin conditions, often just by looking at them.
For instance, take a common skin infection called Impetigo. If a doctor sees sores around a kid's nose and mouth that have broken open and form these classic honey-colored crusts, their brain immediately jumps to that specific diagnosis. That one visual clue is often all they need.
Or think about shingles. It's not just the painful blisters that give it away, it's the pattern. The rash almost always pops up in this very specific linear cluster that follows the path of one single nerve. For a trained eye, seeing that pattern is practically an instant diagnosis.
Okay, so we've covered the observation and the diagnosis part,
But what happens next? How does all of this medical detective work get translated into the administrative side of things? Let's peel back the curtain on how your exam actually becomes a medical bill.
So, how does all this stuff, that first glance, the measurements, the final diagnosis, how does it all add up? Well, every single thing is documented in a very systematic way. And the reason for that is because it all gets quantified to figure out the complexity of your visit, and that complexity is a key part of determining the bill.
The whole visit, from start to finish, gets distilled down into a level, from minimal all the way up to high. And that level is based on a few things: the number of problems you have and how bad they are, the amount of data the doctor has to look at, and the overall level of risk to you as the patient.
And here's where you can really see how it works. Let's say you have a single chronic illness, but it's stable. That visit might get coded as low complexity. But if that exact same illness is suddenly flaring up, or if you show up with a brand new problem that nobody's diagnosed yet, the complexity immediately jumps to moderate. This is literally how the story of your health gets translated into the language of medical billing.
So what's the big takeaway from all this? It's that your doctor's visit isn't some random series of events. It's a highly structured process. It's a story that starts with a glance, gets depth from precise measurements, finds its plot with diagnostic patterns, and then gets summarized into a code based on its complexity. It's a whole system designed to turn a conversation into clear, actionable data.
So this whole process, it's not some big mystery. By understanding how your clinician is looking, measuring, and documenting everything, you become a much more informed and empowered partner in your own healthcare. So the next time you're sitting on that exam table, what new details are you going to notice?